go. Just getting started here. Okay. So first of all, I'm just going to go over really briefly an overview of what we at CCSN have been doing for liver cancer awareness in the past year. If you follow us on social media, you've probably seen this little blue liver cancer graphic dozens of times over the past year or so as we promoted our various initiatives. In October of 2017, we started working on this campaign with various partners when we realized that liver cancer doesn't have a lot of direct support for awareness in Canada. There's liver health organizations, of course, that do highlight liver cancer, but it's still very much kind of a whispered disease compared to many other cancers. It's a cancer that faces a lot of stigma associated to it. Liver cancer, there's a lot of different kind of diseases that can advance to liver cancer, and those diseases are associated with a lot of stigma, and it can be difficult to reach out and speak to patients and caregivers, and we think that is a major reason why. So about a year ago, we set out with a goal to complete some initiatives in our campaign that would help this happen. And now a year later, we've not only reached those goals, but we've now surpassed them, which we're really proud of. So we started with an information portal on our website, survivornet.ca. We have many sections on various cancers on our website under our Learn section, but we really wanted to flesh out the content in the liver cancer section. There wasn't a lot there. And we wanted statistics and facts coming from Canadian sources as much as possible, because that was kind of lacking on the internet in terms of finding one concise space for facts about liver cancer from a Canadian perspective. The portal also includes sections such as risk factors, prevention, caregiving, as well as links to blogs and Canadian liver cancer organizations, as well as international liver cancer organizations. We also created a dedicated Twitter account, at LiverCancerCA. We're pretty infamous for our Twitter accounts. We have 12 total as of this recording. And it was really important to us that there was a liver cancer dedicated portal because there wasn't one before account, It shares articles about liver cancer from Canada and around the world, and regularly shares content from our campaign and retweets from other liver organizations. So if you're on Twitter, we would really appreciate you following our account if you want to learn more and continue learning more about liver cancer in Canada. We've also created an advisory council for individuals affected by liver cancer. It's for patients and families and anybody who wants to make a difference in an advocacy level, on a policy level. We were delighted to also invite, for example, Andrea Wilson from Blue Fairy, which is an American liver cancer organization, because she's been immensely helpful in resources and advice in our campaign, and continues to be a great resource for us in terms of moving forward with our campaign. So anybody is invited to join that advisory council if they want to make a difference to liver cancer in Canada. And we just released a report on Monday the 1st, actually, based on a survey provided to Canadian liver cancer patients and caregivers. The report's available to read on our website. It's currently featured on our front page, survivornet.ca. This one, well, you're all here for it. It's the educational webinar right off from the bat. Back in October, we wanted to host this webinar, and we wanted to kind of tie it in with Liver Cancer Awareness Month, which is October. So here we are. Thank you for attending. And lastly, this is a new one. We haven't really announced this one yet because it's brand new news. We will be hosting a legislative reception at Queen's Park in Toronto in the early spring. More details will come soon. Like I said, this is brand new, but one of our goals was to get liver cancer awareness on a policy level, start talking about it on a policy level. So that will be coming up as well. So yeah, that's what we've been doing. If you'd like to get involved with any of these initiatives or are curious to learn more, definitely visit our website, send us an email if you have any questions about that. So with that, I'm going to welcome our first panelist today. So Dr. Mamatha Bhat is currently a staff hepatologist and clinician scientist at UHN's multi-organ transplant program and U of T's Division of Gastroenterology. She's developing a research program to enable precision medicine in hepatocellular carcinoma, non-alcoholic steatohepatitis, I hope I pronounced that right, and liver regeneration in the context of liver transplantation. And as I said, today she will discuss hepatocellular carcinoma in more detail, which is the most common form of primary liver cancer. So go ahead, Dr. Bhat.
Okay. Thank you very much, Allison, for the invitation to present today. So I've been interested in HCC for some time now from both a clinical and a research perspective, and I'd like to share these different perspectives with you as part of my presentation today. Next slide, please. So, hepatocellular carcinoma is the most common primary liver cancer, represents 90% of all liver cancers, arises most often in the setting of chronic liver disease. And these chronic liver diseases include fatty liver disease, alcoholic liver disease, hepatitis C, hepatitis B, autoimmune liver diseases, hemochromatosis, as well as various other chronic liver diseases. And I'll explain to you a bit of the pathogenesis in future slides. Most commonly, HCC arises once cirrhosis has developed. So 90% of cases, 90% of patients develop HCC in the context of cirrhosis. And this is what makes HCC very different from other cancers. So other cancers don't arise in this kind of environment where there's ongoing inflammation and the possibility of accumulating cancer-related mutations. This cancer is usually diagnosed in patients who are 50 years or older, and there's a strong male preponderance. So more males than females are affected. So 2.5 times more males than females are affected by HCC, and this is thought to be due to sex hormones such as the androgens and estrogens. So estrogens being protective against HCC. Next slide, please. So how does this differ from other types of liver cancer? So other primary liver cancers include cholangiocarcinoma, fibrolamellar HCC, hemangiosarcoma, hepatoblastoma, but the more common types of liver cancers are actually metastatic, meaning that they represent spread of disease from other organs, including colorectal, breast cancer, lung, pancreatic, neuroendocrine, and melanoma. So these are metastatic to the liver. Next slide, please. So in terms of the pathogenesis of HCC, which is the focus of today's talk, so HCC, as I mentioned, arises in the setting of different types of chronic liver disease. So what this means is that you have, say, for example, hepatitis C or alcohol or fat that serves as an insult to the liver, and there's inflammation, so the immune system reacts against these different insults, and there's ongoing inflammation and oxidative stress, and over time there's accumulation of scarring of the liver, which leads to cirrhosis ultimately in many patients. But in addition, so the liver has this regenerative ability, which is very unique to solid organs. And so when the liver regenerates, it regenerates in response to this insult from ongoing inflammation. So it wants to regenerate or repopulate the liver with new cells. Because there's ongoing damage, the liver is triggered to regenerate. And as it regenerates, there's the possibility of accumulating genetic alterations or mutations. And if you look at the figure on the right now, so as time goes on, there is the possibility of accumulating mutations that result in the development of abnormal liver nodules, and over time dysplasia, and finally hepatocellular carcinoma, because of these ongoing mutations that accumulate. So this is what happens in the context of HCC. So over time, there is the possibility of accumulating cancer-associated mutations, which result in the development of HCC. Next slide, please. The epidemiology of HCC. So this is the fifth most common tumor worldwide. There has been a rising incidence in the Western Hemisphere, so US, Canada, Europe. There has been a rise in the incidence mainly related to hepatitis C, fatty liver disease as well, and alcoholic liver disease. And this is also alongside the improved survival of patients with cirrhosis. Now, if you look at Canada, so we have a 3.1 to 4.1 per 100,000 people incidence of liver cancer based on this map. And you can see that there are different areas of the world, especially China and sub-Saharan Africa, where HCC is much, much more common as compared to the Western Hemisphere. But certainly there is a rising incidence in Canada because of the hepatitis C in our population, which right now is a curable disease, hepatitis C, with the excellent therapies that have arisen in recent years. But fatty liver disease is starting to increase significantly in the context of increasing diabetes and obesity. And certainly we anticipate a rising incidence by virtue of fatty liver disease as well in the future. Next slide, please. The unique considerations of HCC. So HCC is often diagnosed at an advanced stage. So in the Western Hemisphere, 80% of patients are diagnosed at an advanced stage of HCC. This is because of various factors. So the onset of HCC is insidious. People often may not know that they have cirrhosis and therefore may not be screened for HCC. Screening is recommended in patients with cirrhosis and certain higher risk populations with hepatitis B, although the guidelines differ from one jurisdiction to the next. What we recommend in terms of screening is an ultrasound every 6 months, plus or minus an alpha-fetoprotein level in the blood. In terms of biomarkers, alpha-fetoprotein has been used, but lacks specificity as well as sensitivity in terms of detection of resectable disease. And we don't have good biomarkers really to detect resectable disease. And then finally, once HCC is diagnosed, the underlying cirrhosis with associated liver dysfunction can limit what kind of treatment a patient has access to because the underlying liver dysfunction is limiting. So this is also what is very unique about HCC. So given that it develops in the setting of cirrhosis most of the time. And the liver is actually the metabolic factory of our body. It produces clotting factors, produces bilirubin, detoxifies substances, is able to convert medications to their active form. And there's a whole long list of different types of functions that it serves, including converting sugars, lipids, fats, proteins into different forms. So it's certainly an underappreciated organ, but the reality is that often patients have cirrhosis, which can affect what kind of treatment can be offered in terms of HCC. Next slide, please. Potential symptoms, so these include weight loss, fatigue, loss of appetite, jaundice, blood in the stool, fluid in the abdomen, but these symptoms tend to arise when HCC is advanced, and most of the time the early stage disease is going to be asymptomatic when diagnosed during screening tests. Next slide, please. The management of HCC is based on stage, but not only stage, but also the liver function. So this is, again, what is very unique to HCC in terms of placing it in the context of liver function. So if you look at stage 0 disease on the left, so this is very early stage, and these are curable with ablation. And I know Dr. Mujoomder will be talking more about the radiological, the interventional strategies that are available. Early stage disease, so the next column there, stage A, you can see the parameters into which these fit. So if there is significant liver cirrhosis and there's increased pressure within the liver, then you may need to consider transplantation. But if the pressure is normal, then resection is a possibility if this is still early stage disease, and ablation as well, again, can be a curative therapy. So whatever is in green on the left is curative treatment, and these are associated with a median overall survival of greater than 60 months and up to an 80% 5-year survival. And then on the right, you have intermediate stage disease, which is multinodular, meaning multiple different spots within the liver, so liver cancer lesions within the liver, and these are addressed with chemoembolization. And advanced stage disease, so sorafenib is the one chemotherapeutic agent that I will get into in terms of the next slides. So this is the one chemotherapy that really has been shown to have an effect in terms of overall survival prolongation, and then finally best supportive care for stage D disease. And these are the median overall survivals associated with intermediate and advanced HCC with sorafenib, 11 months for sorafenib. Now, on the right-hand side, you can see the figures of the different treatments, and I know Dr. Mujoomder will speak to you more about the first two, which is radiofrequency ablation and transarterial chemoembolization. Also, resection is the third figure on the right, and then you have liver transplantation as an option as a curative therapy for certain patients. Next slide, please. In terms of the systemic therapy, so this shows you a slide. This is a figure of all the different systemic therapies that have been in trials over the last several years, and they've been targeting different proteins involved in different cancer-related pathways, including the RAS-RAF-MAP kinase pathway, the mTOR pathway, so various different types of cancer pathways. And there was this huge effort to really characterize HCCs from a molecular perspective that culminated in the publication of the Cancer Genome Atlas study in Cell in 2017, so a year ago. And what that really showed us, that huge study, which attempted to characterize HCCs using different types of data, so gene expression data, genomics data, methylation data, so different types of data. And what they determined was that there are various types of cancer pathways. So HCC has various cancer pathways that are represented, and it showed us that likely for HCC, the best strategy moving forward would be more combination therapy for systemic chemotherapy as opposed to monotherapy. And I think moving forward, it will be important to consider better characterizing the tumors that we treat, the cancers that we treat, as has been done in the other cancers, like say for breast cancer or colorectal cancer. There's been much more of this approach to really determining what are the drivers of the cancer, meaning what are the cancer pathways that are activated and how can we optimally treat each individual patient. So if you look at this, so at the top you see sorafenib, so that's the one medication, that's the one chemotherapeutic agent that targets a specific cancer pathway that was published in 2008, so 10 years ago, and that's the one chemotherapy that really stood the test of time over the last 10 years, and several different therapies have been tried and compared to that gold standard. And over the years, there have been additional second-line type treatments that have arisen, including regorafenib, and then lenvatinib more recently has been compared to sorafenib and achieved possibly similar efficacy. And more recently, there's been the very interesting development of the immune checkpoint inhibitors, so immunotherapy. And so you can see at the right of this figure, there's mention of nivolumab and pembrolizumab. So these are PD-1 inhibitors. And I'll go through the how these therapies work, but it's very interesting in terms of their targeting the immune microenvironment in the cancers and allowing for the immune system to really attack the cancers. So I will show that to you in the next slide. It's very interesting. Next slide, please. So as I mentioned, the mainstay of therapy for advanced HCC has been sorafenib since 2008. And now, so if you look at the figures below, you will see that the T cell on the left is turned off by the tumor cell. So the tumor cell binds to the T cells. T cells are immune cells or white blood cells that can fight off cancer. And what these cancer cells are able to do is to bind to these T cells to inactivate them. And then these immunotherapy drugs, what they can do is then block the tumor cells from inhibiting the T cells. And so this is how the T cells can then be turned on and can fight off the cancer. So this is the very interesting new type of treatment that has been tested in clinical trials and was published over the last year. So nivolumab and pembrolizumab, and certainly patients achieved partial to complete response in 19% of cases. So the difference in terms of therapy is that, say, sorafenib is more of a cytostatic therapy, meaning that it doesn't result in destruction of the cancer. It results in more stabilization and not necessarily regression of the cancer, but immunotherapy is showing potential that it can actually result in some kind of destruction of the cancer as well. So there is now ongoing trials comparing immune checkpoint inhibitors such as nivolumab in head-to-head trials with sorafenib, which has been the gold standard. And we should start seeing results of those trials over the coming year, which I think will be very exciting. And I should also point out that the Nobel Prize in Medicine this week was won by Dr. Allison in conjunction with a Japanese scientist for his identification of immune checkpoint therapy as a strategy for treatment of cancer. And I think that is quite promising in the context of HCC. Next slide, please. So in summary, HCC is the most common primary liver cancer, fifth most common worldwide, arises in the context of underlying disease of the liver, ongoing inflammation, and I think this makes HCC very unique in terms of the considerations for management. Develops in patients age 50 and above. Management of HCC depends on stage as well as liver function. Curative therapies include RFA, resection, and liver transplantation for early stage disease, and sorafenib is the standard chemotherapy for advanced HCC, although there are very interesting and promising therapies on the horizon, such as immunotherapy, and there is a consideration being given to combination of immunotherapy with others in order to optimize the efficacy of chemotherapy in HCC. So I think there's a lot of promise in terms of strategies for advanced HCC in the near future. So thank you for your attention, and I think we'll move on to Dr. Mujoomder at this stage.
Yes, thank you so much, Dr. Bhat. That was an excellent presentation. I definitely learned a little bit as well. There's a lot to take in with HCC, and you've summarized it really well, so thank you.
Thank you.
So yeah, as Dr. Bhat said, our next presenter is Dr. Amol Mujoomder. He is an interventional radiologist at London Health Sciences Centre. He is an associate professor of radiology and oncology at Western University in London, Ontario. We first got an ear of Dr. Mujoomder when he was featured in an article with CCSN in December of 2017, which discussed Ontario's lack of coverage for innovative IR treatments for liver cancer. The focus of that article was on Y90, which I know Dr. Mujoomder is going to discuss a bit in his presentation, and how because it wasn't funded, the family of the late former amputee Norm Jameson had to actually use GoFundMe to fund for the treatment for Mr. Jameson, and unfortunately it was a little too late for him, and he passed away soon afterwards. And that whole thing kind of inspired us to start this campaign for liver cancer. So we're very delighted that Dr. Mujoomder could join us today for this presentation. And with that, Dr. Mujoomder, you can go ahead.
All right, thank you very much, Allison, for that kind introduction. And thank you for the invitation. Why don't we dive right in? So we're going to talk a little bit about interventional radiology therapies for liver cancer. If you could advance to the next slide, please. So these are just my disclosures, and if we keep going. So just to summarize what we're planning to talk about, I just want to explain a little bit what's the role of the interventional radiologist on the liver cancer team, because we're not a really well-known specialty amongst the general public. And I also wanted to talk a little bit about what are the different therapies in interventional radiology, or IR, for liver cancer, and really those are typically either ablative therapies where we burn or freeze or destroy tumors with energy, or we do therapies through the plumbing or through the vessels where we either inject bland particles, we inject chemo attached to particles, or we inject these radiation beads called Y90. I'll talk a little bit about the patient experience as well as the risks and side effects of these different types of procedures. Next slide, please. So the role of the radiologist, the radiologist is kind of a hidden figure sometimes in the hospital, but I believe has a pretty central role in our multidisciplinary rounds on cancer. We call them tumor boards, where different doctors sit around and they discuss patients. So in the setting of liver cancer, we have a liver cancer tumor board. And the person who is sort of interpreting all this imaging, which helps guide therapy, and mostly in this context would be CT scans and MRIs, is the diagnostic radiologist, and the physician who would perform these sort of image-guided procedures with ultrasound, CAT scans, or live x-rays or fluoroscopy would be the interventional radiologist. And sometimes we wear the two hats in those rounds. And really, along with the hepatologists like Dr. Bhat and transplant surgeons, oncologists, radiation oncologists, these typically form our liver cancer tumor board. Next slide, please. So what kind of procedures do we perform in interventional? Well, sometimes we meet people very early on in terms of doing liver biopsies. We don't typically do liver biopsies for liver cancer, but that may change, especially based on the last presentation in the future with some of the more specific therapies. But we certainly meet people in the biopsy setting, but we really meet them more in the therapeutic setting, where we're meeting patients in our clinic to discuss about things like ablation or these transarterial therapies, we call them. And these are procedures that we typically perform in a team sort of setting with an interventional radiology physician, an IR nurse, and an IR technologist. Can we go to the next slide, please? There we go. And this is kind of an example of our team at Victoria Hospital. So you can see it's really, a whole bunch of us. We have physicians, we have our x-ray technologists, we have our nurses, receptionists, facilitators. So we have a pretty large team, and everyone is there basically for the patient. So it's kind of nice to work in an environment where we really have the patient in mind and kind of a holistic approach to treating cancer. So we go to the next slide again, please. So let's talk a little bit about ablative therapy. So maybe the next slide as well. So this is kind of just a very simple scheme, just in fact showing an RFA, where you have a needle in the patient, ideally through the tumor, hooked up to a device or a generator. You have a grounding pad that's also connected to the generator, and you basically run a current through the patient. If we could just go forward. So really, when we talk about these ablation therapies, we're trying to sort of mimic or rival a surgical treatment, but really the goals being that we want to be minimally invasive. We don't want to be like a surgery, which involves a big incision. We want this to be something very minimally invasive. So our procedures typically involve a tiny incision through, with half the size of my pinky. We want, though, that despite it being minimally invasive, we want it to be maximally effective and kill all the tumor. We also want to destroy the tumor, okay, and have good margins around the tumor, but not destroy any vital structures in the liver. And ultimately, we want to do all of this and we want to improve survival. Next slide, please. So typically, the patients that we are seeing with liver cancer tend to be people with small liver cancers, usually less than 3 centimeters, or they can have a few, very small liver cancers. They must generally have good preserved liver function. As in the previous presentation, liver cancer is typically associated with liver cirrhosis. We want people's liver cirrhosis or liver disease to be fairly early, because once the liver disease progresses, people are generally not candidates for this type of therapy. And usually they tend to be poor surgical candidates. And then we tend to use these now as what we call a bridge to transplant. Liver transplantation is really associated with the best long-term outcomes with people with liver cancer, but there are very strict criteria to transplant people. So we will sometimes treat their liver cancers with these type of therapies to keep them on the list so that we don't allow their cancer to grow beyond the criteria for transplant. So we sort of bridge them until, because it's the reality is people will wait. They don't get a transplant instantaneously. The other thing is sometimes we use it in combination with things like chemoembolization. In the future, this may be in combination with more systemic type of therapies, as there is some data emerging in that regard as well. Can we go to the next slide? So we have different tools in our toolbox in interventional. Mostly they involve RFA and microwave. It's rare that we do the cryoablation. So these are just different ways to treat liver cancers with different energies. With RFA, which stands for radio frequency ablation, and microwave, these are different energies along the electromagnetic spectrum. Cryoablation is a freezing type of procedure that's less commonly used in liver cancer. If we go to the next slide. So we kind of go ahead and we kind of divide it into barbecue, microwave, and freeze. And these are, you know, sound facetious, but these are the analogies actually used to help explain this to patients. And they typically, you know, we say we're going to shish kebab and barbecue the liver tumors, and that's something that most people can understand. We'll go to the next slide. So what's the patient experience? So typically these are patients that we see them in our clinic to sort of usually after a tumor board type of discussion, where we sit down with all the different types of specialists and figure out the best therapy and sort of the goals of the therapy. And then we discuss that in our clinic. This is an outpatient procedure. People come to hospital, they have the procedure, and they generally go home. And we really only admit patients if they're very sick or have high medical risk, or if we run into any type of complication. And every center is a little bit different, but we typically do these with moderate sedation using a couple of medications and some local freezing. And we mostly use ultrasound to guide this, but sometimes we have to use a CAT scanner or sometimes both. And we tend to send everybody home with a little bit of analgesia and, you know, some medications for nausea, and usually a stool softener because our analgesia medications can be constipating. And we see the patients back in clinic in about 4 to 6 weeks with a CAT scan as well as the clinic visit. Next slide, please. So this is kind of a typical image of a CAT scan. Actually, if we go back, there we go, perfect. So this is, you know, CAT scans are a little bit hard to interpret, but that arrow is pointing to a bright spot, which is actually a tumor inside the liver. So that big, you know, these are all shades of gray, so I apologize, I'm not able to use a mouse and point them out, but this is kind of like we're slicing up people like a slice of salami. So to the left of the screen is that organ, is the liver basically, and that spot, we know just from our experience with interpreting CAT scans that spot in the liver is in fact a liver cancer. There are some other subtle findings that we look at to tell us that liver is in fact a cirrhotic liver. So even if the patient doesn't give a history of liver cirrhosis, sometimes people present like that because it's asymptomatic. And so we know from interpreting that is in fact a small liver cancer. And this patient was actually referred to my clinic for an ablation procedure. So if we just go to the next slides, please. And this is an ultrasound representing the exact same thing. So the arrow is pointing to the black spot, which happens to be the same liver cancer that you saw in the CT, and it's sort of surrounded by the meat of the liver. So it's well into the meat of the liver. And then what we see on the subsequent images in the middle and to the bottom right of the screen is we've actually put a needle through the tumor and we've heated up with some energy. This is an RFA procedure. And all that bright stuff you see in where the black spot was is really gas. And so we know that tumor is nicely cooked by the end of the procedure. And usually we measure the temperature and things like that. So we know that at the end of the procedure that it's probably well cooked. If we go to the next slide, when I see them back in clinic in about 4 to 6 weeks, we kind of compare the CAT scans before and after. And basically, you know, once again, using our knowledge of interpretation of CT scans, we can see that the bright spot is no longer a bright spot, it's gone. There's a little scar there in the liver, and the liver has a bit of forgiveness to it that basically once you burn a small spot, it'll sort of heal around it. And we monitor that patient, you know, we have a whole protocol associated with that, and basically monitor them to make sure that nothing recurs in that area, and that because they've produced cancer once, they're sort of at higher risk of developing another liver cancer. So we certainly have to keep an eye out for that. So we'll just go to the next slide. So what are the risks of doing this type of procedure? And I apologize. So the risks of doing this type of procedure is we can run into problems with bleeding. Liver cancer, or patients with liver cancer tend to have liver cirrhosis, which thins out their blood. It makes the little cells called platelets in the blood tend to be lower. So they're at higher risk of bleeding. That being said, it's still fairly uncommon to run into any major bleeding complications. Okay, so it's usually, I would say, 1 to 3%. that area we burn could get infected, and there's some conditions that can make it a little bit higher risk for infection, but that's also quite rare. We can cause a bit of collateral damage. We don't want to burn the bile ducts and the major blood vessels and things like that. We also don't want to cause damage to other organs. Sometimes the stomach is nearby, sometimes the colon is nearby. So we certainly want to be cognizant, and there are techniques we can use to anticipate and prevent that, but we don't want to cause a bigger problem than what we started with. But however, that being said, the risk of major complications is fairly rare. Next slide, please. So now we kind of move into these arterial therapies, and arterial meaning through the blood vessels or the plumbing of the body. So we kind of divide those into chemoembolization, bland embolization, and Y90. If we go to the next slide, please. So what are the goals and rationales of doing this type of therapies? And really, chemoembolization, or TACE is kind of the acronym, is really the mainstay therapy. Well, the liver has a double blood supply feeding it. It's got a portal vein that feeds the bulk of the tissues, and it's got liver arteries. And the liver arteries, for whatever reason, tend to feed the tumors. So we sort of take advantage of that, because if it only had one blood supply and we blocked it, you could actually potentially kill that organ, which is what we'd want to spare the normal tissues but kill the tumor. And then really the goals of care depend on the patient. So sometimes it's kind of a palliative or standalone therapy, although that's rare now that we do have systemic medications, but usually we use it in combination with something like sorafenib, or sometimes with my radiation oncology colleagues, we'll do a chemoembolization and then also zap the area with radiation. So sometimes it's just a palliative type of therapy. Well, sometimes people are potential transplant candidates, but they're beyond our transplant criteria. So we try to shrink the tumor to bring them into transplant criteria. And then sometimes we're trying to bridge people. And I would say that's a big chunk of what we do, is people that are transplant candidates that we're just trying to keep their cancer in control, so that they make it to their liver transplant and do not progress and become ineligible and fall off the list. This is a non-curative type of therapy, though, and it's important for people to understand that. Can we go to the next slide? So this is just a diagram that I borrowed from a journal article that sort of shows that big cancer in the liver, and the blood, you can see kind of a catheter snaking through the liver artery or hepatic artery right up until the feeders to this tumor, the blood supply. So that's really what's providing the nutrition. And we mix up our chemotherapy and inject it directly, so it sits into these arteries in the cancer and elutes this cytotoxic or toxic poison to the cancer cells. And then we also tend to block the blood supply. So we just go to the next, before you go to the next slide, you can see on that we're sort of going through the groin artery. We also tend to go through the wrist a lot more as well. It's all, the plumbing is generally connected, and it's a little bit nicer for the patients. And that bottom right image just shows what an angiogram looks like, which I'll also show you an example of. So we'll just go to the next image, or next slide. So really this is a little bit more involved. It involves an admission to hospital the night before. We sort of hydrate and give some pre-medications to prepare the patients. But once again, a lot of this is discussed in our clinic visit, so that when patients come to hospital, they're sort of mentally prepared and mentally ready. They've also already been discussed in our tumor board. And the treatment generally involves doing an angiogram of the liver. So I always tell people that they're used to hearing about angiograms of the heart. Well, we tend to do an angiogram of the liver, either through the wrist or the groin. Once we map out that anatomy, we inject either bland particles, but mostly in our practice, it's more of a chemotherapy into the liver arteries, and then we sort of block them as well. So we use live x-rays to do this in an interventional radiology suite, and people are generally discharged the next day with antibiotics as well as medications for pain and nausea. We tend to see them back in clinic in about a month, usually with imaging, blood work, as well as just a clinical assessment. Go to the next slide. How does it work? Well, really, you try to starve the tumors of the blood supply, and we call it a bit of a choking effect. And you also try to have a toxic effect on the cancer cells with the chemotherapy. I call it a 1-2 punch. Which is better? Should we just do bland or should we just do chemo? Most of the studies have kind of proven that chemoembolization is sort of the standard, but it's not cut in stone. Some recent studies are questioning whether chemo is truly better, but generally speaking, chemoembolization is the mainstay. Can we go to the next slide? So let's talk a little bit about Y90. Go to the next slide, please. So Y90, what's really the rationale? Well, we know that radiation can be lethal to cancer tissues if we provide a sufficient dose, but we also know that the normal liver is sensitive to radiation and in fact has a threshold that it could actually be lethal if we didn't do it properly. And these Y90 spheres, and with Y90 being in kind of a medical isotope that sort of emits a very high energy photons, basically there are these little millions of high dose sources of radiation that will preferentially go into the tumors and sit and emit this very high dose radiation while sparing the normal liver. And that will allow us to give a very high dose of radiation that will preferentially treat cancer and spare the liver. Can we go to the next slide? So this is kind of a little drawing to sort of represent that. We see a catheter at the bottom of the screen and these little beads that are preferentially going into the cancer cells and emitting this high dose radiation. We'll go to the next slide. But that being said, we can talk a lot about Y90. Currently, unfortunately, it's not funded in Ontario. It is funded in several other provinces in Canada, in Alberta, BC, New Brunswick, and PEI of all the places. We're certainly working on this. I'm working on this specifically myself with Cancer Care Ontario, but this change takes time. So unfortunately, as we heard at the beginning, some people have to pay out of pocket for this therapy, which is unfortunately the reality, and we're working very hard to change that so it's available for all Canadians and Ontarians in particular. Can we go to the next slide? So what's the patient experience? Well, chemoembolization and blind embolization is pretty similar relative to a Y90. The only difference is Y90 is more of an outpatient procedure as opposed to an inpatient chemoembolization. With the chemoembolization, we do one angiogram and a therapy in the same sitting, and they may get multiple treatments, whereas the Y90 treatment generally involves a planning day where you do a liver angiogram and you do some planning with a nuclear medicine. We call it a lung shunt study. So it's a bit of a planning day where we kind of measure how much blood is being shunted into the lung. And we use that information along with the CAT scan measuring volumes of the liver to figure out a dose of how much radiation is going to be effective on the cancer and spare the liver. And then the next time we bring them back 1 to 2 weeks later and do the actual Y90 procedure, which is also a fairly similar procedure. They usually recover for a few hours and go home, as opposed to the chemoembolization procedure, patients who generally have to stay in hospital for about 2.5 days. Go to the next slide, please. The risks are fairly similar. Once we access your blood vessels, people can run into bleeding, or we can scrape or damage things. There is a small risk of infection. Rarely people can run into problems with ulcers in the stomach or the intestines, but I will tell you it's quite rare. In fact, I can't say I've ever seen a case myself. And we could run into things with liver failure. Certainly with people with advanced liver disease, we have to be careful with doing these type of procedures. So we have our ways of evaluating patients' liver cirrhosis to make sure that they're good candidates. And then specifically to the Y90, they can get a bit of a radiation liver disease, which characterized really by nausea and vomiting. You get a bit of a hepatitis. Can we go to the next slide? So we talked a little bit about some of the side effects. So you get sort of flu-like symptoms. Most people really feel tired, though. That's the most common thing. Sometimes, with the chemoembolization, sometimes people rarely lose their hair and have some chemo type effects like that. Pain is not as common. With the Y90, we do put people on a bit of precautions. Can we go to the next slide? How do we determine people? Well, really, that's the whole point of the multidisciplinary rounds. We sort of, hash it out amongst our colleagues. And that, to me, that really determines the best care for patients, is when everybody's at the same table and we have a plan, sometimes even before we've met the patient. Can we go to the next slide? This is just an example. It's like a patient is standing in front of you and a CAT scan, we call it in the coronal plane. So the R and L are the right and the left, and you can see the liver, and that bright spot is a big liver cancer. So we'll go to the next slide. This is what an angiogram looks like. It's called a subtraction angiogram. So we subtracted everything, and you can see that big cancer, all that blood supply filling it. And this is a patient I treated with Y90. We'll go to the next slide. This just shows all the radiation kind of sitting in that tumor. And we'll just go to the next slide in the interest of time. Now, this is a ideal textbook patient, so please don't think that every patient is this curable or treatable, but this patient happened to be cured, even though this was not a curable situation. But over time, really that section of the liver just shrunk down, and the cancer kind of died and melted away. This patient's actually alive 4.5 years later and developed a very small liver cancer that we treated as well a second time, just with an ablation. Just goes to show you that with liver cirrhosis, we have to keep an eye on the liver. Next slide, please. So next steps really is we're working with, in particular in Ontario, and this is a national webinar, but obviously in healthcare is very provincial. So I'm working with Cancer Care Ontario, and different colleagues of mine across the country are working with their funding bodies to try and get these more emerging technologies funded, like microwave and Y90. And we're certainly also want to promote with healthcare providers that the importance of multidisciplinary care, getting to transplant centers for discussing these patients to make sure that patients receive the best possible care. And I think next slide is the conclusion. So interventional radiology has an important role along with the other specialists in the multidisciplinary management of liver cancer. Sometimes we're curative with our ablation therapies, or we have palliative treatments, and sometimes we're bridging people or actually trying to downstage them for liver surgery or transplant. And as mentioned, we need to work with our funding agencies to help these different technologies get funded. And I think that's everything. So thanks a lot for the invitation and for your attention. Sorry if I went a little overtime.
Oh, that's fine, Dr. Mujoomder. Thank you so much for that presentation. It was fantastic. And we really appreciate all the work you're doing to try and get Y90 funded as well. As we mentioned briefly earlier, it was something that kind of spurred this campaign forward when we first started. So thank you for all your hard work.
No problem.
There's his last slide there. So last but certainly not least, our third panelist today is Dr. Gregory Powell. He's a retired professor of family medicine and emergency medicine at the Faculty of Medicine at the University of Calgary. He's also the founder and CEO of the nonprofit Shock Trauma Air Rescue Society, STARS for short, which is a helicopter-based emergency transport service. And he's here today primarily because he's also a survivor of hepatocellular carcinoma. So I'm going to go ahead and let him speak on that. He doesn't have any slides, just this one here. So go ahead and listen. Go ahead, Dr. Powell.
Thank you very much, Allison. And I think my previous two speakers did a great job, and there was times I thought they might be reading from my chart because I have a fairly typical case of HCC. So I'm an emergency physician, and I'll try very hard to speak as a patient, but I may drift occasionally off into the medical wonderland. So to put you in context, I have hemophilia B, which many of you will know to be a bleeding disorder that is inherited. Mine was relatively mild, but over my lifetime, I did have the need for blood products from time to time. And in the mid-1980s, I did receive some blood products which contained hepatitis C and could well have contained HIV. And if they did, I probably wouldn't be here, but I unknowingly got hepatitis C and lived with it for many years before it was diagnosed. The cirrhosis developed and continued to the point where I was on a transplant list within days of transplantation. And just at the last minute, a clinical trial came up and a research nurse said, you should probably go in this trial. And within a few weeks, my viral count was 0, and I was essentially cured by the newer direct-acting antiviral drugs. So it's great to be a medical miracle if you can't make them, and gives you a very interesting perspective as a patient on the science and amazing progress that's been made in treating this disease. But as a patient, you may experience two different perspectives. For me, partly because of my medical knowledge, but partly because there was a very active surveillance program that I was put into. So I had an ultrasound or MRI alternating, and I had fairly severe cirrhosis with significant portal hypertension. So they were, those are medical speak, scarred liver and some accumulation of fluid from time to time if I didn't watch my P's and Q's. So the program did detect a 1.2 centimeter HCC at a very awkward place in my liver. And that was through the diligence of hepatologists managing me, and then on to several of Amol's colleagues who looked at it and said, well, that's going to be pretty hard to get at. And they took some very long needles and put 3 injections of 100% ethanol. What a guy has to do to get a drink. I haven't looked at alcohol for many decades. And injected it, and the tumor was nothing as was shown on the previous scan, but a black spot. And it's now 2 years later, and it continues to be clear with only a small residual place of scarring where the tumor was. So I feel very fortunate, but I will describe the reaction of the patient. So if you're in a surveillance program and you're almost expecting to find it, and you're a physician who says, I'm a physician, I'm probably going to get this, and I did, the psychological blow was nevertheless at least a 1x4 to the side of the head. When you've been through almost death, near transplant, and you have ongoing complications, you say, boy, who needs this? And you have an amazing need for a group of a village around you to support you through those things, and I was very fortunate to have that. But the other thing that I think must be harder, that did not happen to me, but I've certainly touched base with friends as patients who have had it happen, which is it's discovered incidentally, not by a surveillance program out of the blue and perhaps more advanced than a 1 centimeter tumor. And I think there's more learning in that time of distress, and there is a great psychological impact that people need to be and are very aware of. But the Survivor Network is a good example of supporting people who have that amazing emotional reaction to thinking they probably have the medical condition that's going to take their life. So I know we're a little pressed for time, and I just wanted to provide you with a very brief look at the diagnosis and treatment from the patient's perspective. And yes, those big long needles going into your liver, just in case anybody asks you, are painful. But managed well, very survivable experience, and very gratifying experience when you think that you were cured for all intents and purposes, and life is going to go on. So I'll stop there, Allison, and say thank you to everyone, and maybe there's time for some questions.
Yeah, that's perfect. Thank you so much, Dr. Powell. Sorry we got a bit pressed for time there, but your story is really important to share as well. It's good to hear your perspective, especially with your medical background as well. So we appreciate it. As he said, we will have time for just a few questions. We're just a bit over time here, but I see we have a few questions coming into the board here. If you do still have a question you'd like to ask, you can go ahead and type it into the questions bar at the bottom of your panel. We'll try and get to as many as possible. If we don't get to your question, we'll see if we can follow up with you after the webinar. So our first question here is directed towards Dr. Bhat. It says, can Dr. Bhat comment on potential treatment pathway changes given potential entrance of PD-1? Particularly interesting since sorafenib and regorafenib, are linked as 1L and 2L with both approved in Canada. So any thoughts on that, Dr. Bhat?
Yeah, so that's hard to say at this stage. The trials that have been conducted so far are quite promising on immunotherapy, I would say. So they were just published over the last year. And I think there's a lot of promise, as I was saying, these have the advantage of being more cytolytic therapies, meaning that they're able to kill off the cancer rather than being cytostatic, which is just limiting the growth or stabilizing the growth of the cancer. So I think at this stage, we really have to see how these treatments compare to the standard of care, which has been sorafenib. And I think that will become clear by next year where these therapies stand as compared to sorafenib. And it's only then at that stage that we will really be able to say, well, where does immunotherapy fit into the algorithm for treatment of HCC? Because I think at this time we don't really know the answer to that. So far, the trials that were conducted were really open label trials and not in comparison to the standard of care. which has been sorafenib in the last 10 years. So I think we really need to wait for the results of those trials to be able to answer that question, how the algorithm changes. And I think that's a great question, but we'll have to see. We'll have to wait until next year to really find out the answer to that.
Great, thank you, Dr. Bhat, and thank you for the great question. The next two questions, in the interest of time, I'm going to combine them slightly. They're kind of in a similar vein. The first one is directed to Dr. Bhat, the second to Dr. Mujoomder. So the first one says, immunotherapies are being tested for advanced HCC. Do you think that these therapies might be studied in more intermediate disease? And relatedly, the following question says, given the new advances in treatment in the pre-systemic area and post-systemic area, how can we catch the disease earlier to maximize benefit for IR therapies? So Dr. Bhat, would you like to go first?
So for more intermediate stage disease, are you referring to?
They're saying here, do you think that the
earlier stage disease
in more intermediate? Yeah, in more intermediate disease is what it says here, as opposed to just being tested for advanced HCC.
Okay, right. That's also a good question. As of now, it's really being tested in the more advanced HCC setting. But I think once we see the benefits in the area of advanced HCC, I'm certain that that will open the door to exploration in the context of earlier stage HCC. The thing is, as an adjunct, but I think earlier stage HCC as it stands is amenable to curative therapy of different kinds, including ablation, resection. In terms of liver transplantation, so those are the three main curative type therapies that are available. Now, whether immunotherapy will be able to help in the early stage disease, I think we will have to see what really is able to do in advanced stage disease, and then thereafter look at whether it could serve as an adjunct in earlier stage disease.
Okay, great, thank you. And again, so Dr. Mujoomder, given the new advances in treatment in the pre-systemic and post-systemic area, how can we catch the disease earlier to maximize benefit for IR therapies?
I think it's a bit early, because we certainly don't have all the information in front of us in terms of maximizing with immunotherapies and these advanced or newer systemic therapies. I think really the key, which was mentioned, is people that have liver disease ideally have to be screened, because we know that if you have early liver cancer, your outcomes and your survival, and ideally, your route to curative therapy is much easier and better. Whereas when we discover liver cancer accidentally, when it's more advanced and not curable, we know the outcomes are much worse. And so really, getting people with liver disease kind of diagnosed and properly screened is really the best strategy as of now. And in terms of the future, right now the future is very exciting, because we do have these multiple different sort of systemic therapies and local therapies, and they're like Dr. Bhat alluded to, is I really think the future is going to be in these either combination systemic or with local regional. Yeah. It's really an exciting future for liver cancer, to really try and, control. Once we hit those advanced stages, the outcomes start to really be quite bad, right? So we really want to, that's why, and part of the reason why immunotherapy is focusing on that population, because we don't have a lot for them right now. And, that's really great. So if we can, translate that to earlier stages, that'll be great as well.
Great, thank you so much, and thanks for the great questions, guys. That's the conclusion. Thank you to all our attendees who asked the question. And with that, we'll conclude the webinar today.